Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back to CardioNerds. My name is Mariana Garcia. I'm a cardiology fellow at the University of Wisconsin. I'm thrilled to be here today. We're tackling one of the most rapidly evolving topics in cardiovascular imaging: how coronary CT angiography has transformed from a simple anatomic test into a comprehensive platform for plaque characterization, functional assessment, and AI-driven risk certification. Hosting today's discussion with me is Dr. Christopher Mason, who is a first-year cardiology fellow at UT Southwestern with an interest in cardiac imaging.
Thank you, Mariana. I'm really looking forward to this conversation. Leading today's discussion is Dr. Joseph Kassab, who is a second-year internal medicine resident at UT Southwestern and a CardioNerds Academy fellow.
Thank you, Chris. I'm so excited to contribute, especially with such a transformative topic, coronary CT angiography. It's easy to hear CCTA and think of it as just a fancy way to look at coronary arteries for blockages. But there's been a shift in how we use this modality. We've moved far beyond asking, is there a stenosis, to asking, what is the plaque burden? What is the plaque composition? Is there coronary inflammation? And is this lesion actually causing ischemia? All from a single non-invasive scan. Today, we're diving into the evidence behind this revolution and are thrilled to have Dr. Michael Gallagher join us in our discussion. Dr. Gallagher is a non-invasive cardiologist and national leader in advanced cardiac imaging. He serves as Program Director of the Cardiovascular Disease Fellowship at William Beaumont University Hospital, Medical Director of Advanced Cardiac Imaging at Corewell Health East, and Professor of Medicine at Oakland University William Beaumont School of Medicine. Dr. Gallagher, thank you for joining us.
Thank you, Joseph. Hello, Mariana and Chris. Thank you all, and thanks to the entire CardioNerds team for inviting me. It's a real privilege to join you all. You've built a highly respected educational platform in cardiovascular medicine, and I and so many others admire the work that you're doing. So I'm grateful to be here and excited about today's conversation.
All right, let's start with the basics. So CCTA has been around for a while, but its role has evolved dramatically. It is a non-invasive ECG-gated CT scan that directly visualizes the coronary arteries, the vessel wall, and the atherosclerotic plaque itself. Dr. Gallagher, can you walk us through the key evidence that has positioned CT coronary as a first-line test, and what makes it different from traditional functional testing?
Of course, absolutely. Thanks for the question. I think one of the most important shifts in modern cardiovascular medicine over the last decade has been the rise of coronary CTA from what many initially viewed as simply an anatomic imaging test into really a true frontline diagnostic test and preventive tool. And historically, our chest pain pathways were dominated by functional testing, stress nuclear imaging and stress echo, treadmill testing, all very important tools, but designed primarily to answer one question: is there ischemia? And that's an important question, but it's not the only question, because ischemia usually reflects a later stage manifestation of coronary disease. By the time someone has inducible ischemia, they often already have substantial atherosclerosis. So CT has really changed the paradigm because it allows us to visualize the coronary arteries directly and identify the disease across the entire spectrum. So instead of asking whether there's ischemia today, CT asks whether there's coronary artery disease at all and how much. And that distinction really matters tremendously. And when you ask about some of the key evidence, I want to talk about a few things. Number one, the landmark randomized trial that really helped move the field was the SCOT-HEART trial. Briefly, the SCOT-HEART trial enrolled over 4,000 patients with suspected stable angina. And the trial showed that adding CT to standard of care reduced coronary death or non-fatal MI at 5 years by about a 41% relative risk reduction, from 3.9% events down to 2.3% events. And longer-term follow-up studies just recently published showed that that benefit persisted out to 10 years. And it was largely driven by greater use of preventive therapies rather than more procedures. And I think the other landmark study to talk about was the PROMISE trial. The PROMISE trial randomized more than 10,000 patients to CT or functional stress testing. And overall, event rates were similar, but CT again led to fewer normal catheterizations, meaning it was better at selecting who truly needed invasive angiography. So when we turn back to the question about, so what makes CT different from stress testing asks, is this patient ischemic today? And CT asks, does this patient have coronary atherosclerosis? And if so, how much plaque is there and what kind of plaque is it? And that really matters because many future MIs arise from non-obstructive plaque that may never cause ischemia on a stress test. And I think this is really fundamentally why CTA has moved to a first-line status in the modern guidelines, because it combines excellent sensitivity and rapid diagnosis and a strong negative predictive value and the ability to directly look at plaque and then to trigger preventive therapy. So if I shift back for a minute, as we talked about stress testing, it's really important to remember that stress testing still has and will always have an important role, in particular in patients with known coronary disease or prior revascularization, in situations where we want to evaluate exercise capacity or when we have physiologic questions. But for many patients with stable chest pain, CT really gives a more complete and an earlier view of coronary disease. So I really don't see CTA and stress testing as competitors. They're complementary tools, but CT has become the preferred first move for many patients because it identifies disease earlier and more directly. So to answer the question of what's my practical approach, I use CTA when the key question is disease detection and plaque burden. And I use stress testing when the key question is ischemia or exercise capacity or hemodynamics or symptom reproduction.
You've mentioned a little bit about the negative predictive value of CCTA. We said it was greater than 95%. So probably a normal CTA would kind of rule out obstructive CAD. And that's very powerful, for example, in the emergency department, even like in the outpatient setting. But Dr. Gallagher, can you touch base a little bit on the limitations, or when does it actually fall short? In other words, in which instances would you, like, as you said, prefer a stress testing over CCTA?
Well, thanks for that question. Yes, CTA is a powerful test, but it's not perfect. So before I talk directly about the limitations, I just do want to make a comment that we need to remember that the success of a CT diagnostic strategy really depends on image quality, and that depends on a good team, from the equipment to the CT technologist to the nursing staff, and then finally to the physician. Quality depends on many things, including heart rate and heart rhythm and breath holding, the timing of your IV contrast and your scanner quality. So you really need to ensure you have a high quality team and a service that's able to provide expert CT interpretation. But as it relates to quality, some specific factors really need to be considered when considering when to use or when not to use CT. And these factors include the patient's age, the pre-chest probability of coronary disease, the presence of heavy coronary calcification, and you need to know your patient's body habitus and certainly renal function. So getting back to some limitations, I think heavy calcification can make stenosis look worse than it is. And we as readers can often overestimate stenosis severity in these situations. And as we'll discuss later, the addition of FFRCT helps, but calcium can still create false positives. CTA is also less ideal in patients with prior stents or prior complex bypass anatomy, in patients with severe obesity or significant renal dysfunction, or in patients who just are unable to cooperate with breathing. But if we turn back to your question about stress tests, it's important to remember that CTA does not replace exercise physiology, and that stress testing will always remain an important test to help diagnose and manage our patients. So my takeaway is that I think CTA is exceptional in the right patient and on the right scanner and with the right team.
That was fantastic. Thanks. That's actually going to be really helpful when we decide which test to order for our patients with chest pain. Just to summarize, Dr. Gallagher, for our audience, who would be that perfect patient to order the CT?
Yeah, thanks for the question. I think the right person to order a cardiac CT is when you really need to combine excellent sensitivity, when you really just need the highest sensitivity test, a test that has strong negative predictive value, a test that allows a rapid diagnosis and the ability to really directly visualize plaque. And so I think this amounts to patients that you see either in the outpatient environment or in the emergency department with new onset chest pain or symptoms that concern you for potential underlying coronary disease. And so in patients, they lack a history of prior bypass or prior stents, and that we need to assess whether or not this patient has significant coronary disease. I think cardiac CT first is the strategy to turn to in a broad group of these patients without known or pre-established coronary artery disease.
Thank you so much, Dr. Gallagher, for this overview of CCTA. That was very helpful. Let's talk a little bit more now, maybe of how we communicate CCTA findings. We know the CAD-RADS system, coronary artery disease reporting and data system, which was developed to standardize CCTA reporting and link findings into clinical management recommendation. And then there's the updated CAD-RADS 2.0, which was published in 2022, which added some important modifiers. Dr. Gallagher, can you walk us a little bit through the CAD-RADS categories and, like, importantly, what are the new modifier in that new version?
Great. Yeah, CAD-RADS has been really valuable because it's standardized cardiac CT reporting. Early on, reports often use vague language like mild or borderline stenosis or moderate stenosis, and this often created confusion for referring clinicians. CAD-RADS gave us a common language that was tied to management. At its core, CAD-RADS is really still based on stenosis severity. So CAD-RADS 0 means there's no stenosis, 1 minimal, CAD-RADS 2 mild, CAD-RADS 3 moderate, 4 severe, and 5 a total coronary occlusion. But what's changed with the latest update of CAD-RADS to CAD-RADS 2.0 is that we've moved beyond stenosis alone. It's added important modifiers for plaque burden with a scale between P0 for no plaque and P1 to P4, or plaque 1 through plaque 4 stages that represent mild to extensive plaque burden, respectively. And in the CAD-RADS 2.0 document, they've also added other modifiers that include the presence of high-risk plaque features, presence of ischemia from CT-FFR, prior stents or bypass grafts are all new modifiers added in CAD-RADS 2.0. So with CAD-RADS 2.0, we're not just saying how narrow the artery is, we're actually communicating the broader disease picture. And that's really important because the future of CTA is integrating anatomy, plaque, and physiology and risk, and not just grading blockages. So CAD-RADS 2.0 helped us move CTA from an image interpretation towards a clinical decision support tool.
What I find really interesting is just moving the conversation beyond stenosis. So, for example, Dr. Gallagher, for a patient that has a CAD-RADS of 2, which would be like a mild 25 to 49% stenosis, but with a P3 or P4 plaque burden modifiers, it is very different than someone with a CAD-RADS 2 and P1. Plaque modifier is essentially telling the clinician that ordered this, yes, there's a stenosis, it is mild, but this patient has heavy atherosclerotic burden and needs aggressive risk factor modification. How do you think this is changing the clinical practice? Should we stop saying non-obstructive CAD as it means benign CAD?
Yes, thanks. I do think we need to be much more careful with that phrase. Non-obstructive only means that the plaque is not causing a severe narrowing. It doesn't mean benign disease. So as you mentioned, a patient with CAD-RADS 2 and minimal plaque burden is very different from a patient with CAD-RADS 2 and extensive plaque burden or high-risk plaque features. The stenosis may be the same, but the long-term risk may be very different. That's where CAD-RADS 2.0 and plaque modifiers are really changing practice. They help us identify patients who may not need a stent, but they absolutely need aggressive prevention, high-intensity lipid lowering, risk factor control, lifestyle therapy, and close follow-up. So I think the shift is from a blockage model to a disease burden model. We are now moving towards an objective plaque burden model that can be tied to management strategy. And personally, when the plaque burden is substantial, I'd rather say high risk, non-obstructive atherosclerosis than simply mild coronary artery disease.
Now, let's dive into a fascinating development within the field, CT-derived fractional flow reserve, or CT-FFR. Invasive FFR is the gold standard for determining whether a coronary stenosis is hemodynamically significant. To estimate FFR in the cath lab, you throw a wire across the lesion, induce max blood flow with adenosine, and measure the ratio of the distal coronary pressure to the aortic pressure. A ratio less than or equal to 0.8 indicates a significant flow-limiting lesion. Dr. Gallagher, can you walk us through how CT-FFR is calculated?
So that's a great question. The easiest way to think about CT-FFR is that it turns a regular coronary CTA into a virtual stress test for blood flow without the need for another scan, without more contrast, without adenosine. The patient's already off the table. Everything happens afterward with software. So how does this work? First, the CT creates a detailed 3D model of the coronary arteries. And then really advanced computational fluid dynamics, the same type of engineering used in like aviation and race car design, simulates how blood would flow through those arteries during maximal hyperemia. And this model uses key physiologic principles that include things like, number one, how much heart muscle needs blood flow, how vessel size relates to downstream resistance, and how the microcirculation responds to vasodilation. And then it calculates the pressure drop across each lesion, similar to what we measure invasively, as you mentioned, with a pressure wire in the cath lab. And then the final result is a color-coded map of the coronary tree with CT-FFR values throughout the vessels. And in general, values above 0.80 are reassuring, and values below 0.80 suggest lesion-specific ischemia. And in general, lower values imply greater physiologic significance. So the practical value is this: is from one resting cardiac CT, we get both anatomy, where the plaque and narrowing are, and physiology, whether that narrowing is actually limiting flow. And that helps us decide who needs a cath lab and who can be treated medically.
That's very helpful. Now, let's talk about some of the studies. We have studies exploring how CT-FFR affects decision-making and clinical outcomes. In the platform trial, use of CT-FFR reduced the percentage of unnecessary catheterizations with non-obstructive disease by 61% compared to an invasive approach alone. The PRECISE trial showed that a coronary CTA plus CT-FFR strategy was associated with decreased rates of invasive angiography without an increase in mortality or non-fatal MI. Dr. Gallagher, can you put these trials in context and tell us how CT-FFR is being used in practice today?
Yeah, absolutely. I think the best way to understand where CT-FFR fits in practice today is to recognize that it has really evolved from being simply an interesting physiologic add-on to CTA into a true clinical decision support tool. Historically, CTA has always had extraordinary sensitivity. If a patient has meaningful coronary disease, CTA is very unlikely to miss it. But the challenge was never sensitivity. The challenge has been specificity. We often saw intermediate lesions or calcified lesions or visually severe lesions that were not actually flow limiting. And without FFRCT, these lesions created downstream uncertainty, and they often led to unnecessary invasive angiography. And so CT-FFR has helped solve that problem by adding physiology to anatomy. And this addition has significantly improved the specificity and the overall accuracy of the test. And that was really validated, as you mentioned, in several landmark trials. The platform trial that you mentioned was really one of the most practice-changing studies. It showed that in nearly 600 patients initially planned for invasive angiography, that a CT plus FFR CT strategy significantly reduced the number of catheterizations that ultimately revealed no obstructive disease. So in practical terms, the unnecessary caths were reduced, as you mentioned, by roughly 60% without sacrificing safety. And that's enormously important for patients, for physicians, and for healthcare systems. It showed that when a CTA is paired with FFR CT, it becomes a decision-making tool that can prevent unnecessary catheterizations with safety. Similarly, the PRECISE trial demonstrated that a CT-first strategy with selective FFR reduced invasive angiography as well, and similarly without increasing mortality or myocardial infarction. So again, better triage, fewer procedures, and preserved safety. So how is FFR-CT used today? I'd say there's a few major domains. Number one, CT-FFR is used as a gatekeeper to invasive angiography. And I think this is probably the most established role, that CT-FFR is used to determine whether intermediate lesions, in particular between 40 and 90% stenosis, are truly ischemia producing. Number two, FFR-CT improves the specificity of CTA. So instead of overcalling a disease by anatomy alone, CT-FFR helps us identify who truly needs revascularization and who can be managed medically safely. And then it's important also to say that FFR-CT provides powerful prognostic information. We've seen that in several research studies. We've seen that abnormal FFR-CT values are associated with worse long-term outcomes. And perhaps the last two brief things I'd mention is that FFR-CT is now being used for PCI planning. This is really an exciting and emerging area, perhaps for another conversation. But the last thing I do want to mention is something we use often here at our health system is emergency department chest pain triage. And we've routinely used cardiac CT and FFR CT to avoid admission in patients who don't require admission, to avoid further downstream testing if it's not necessary, and still maintain excellent outcomes. So if I really had to put it all together, Chris, where is CT-FFR used today? I'd say it's become the bridge between anatomy and management. CTA really tells us what the arteries look like, and FFR CT helps tell us what to do next.
Thank you to Dr. Gallagher. That context for CT-FFR utilization is very helpful. Do you know of any studies or clinical practice protocols in which CT-FFR guides decision-making to pursue a CABG with cardiac catheterization deferred?
So that's a good question. And there's a lot of emerging data in this area. And there's some good work being done by Dr. Patrick Sarus and his team that have looked at the role of cardiac CT and FFR CT in determining who requires coronary artery bypass graft surgery and in what vessels require bypass. And this data is quite exciting. And these authors have shown fairly similar accuracy between a CT with FFR CT diagnostic approach to guide who requires bypass surgery and what vessels should be bypassed as compared to an invasive coronary angiography and invasive FFR cohort. So this data is exciting. Certainly in our center, we're not routinely using cardiac CT with FFR without invasive angiography to send patients onward for bypass graft surgery. However, I do think based upon this exciting novel data that we will be using that as a routine practice in the near future.
Now, let's address the elephant in the room, the limitations. One concern about CT-FFR is that hyperemia is not achieved with a vasodilator like adenosine. Rather, hyperemia is simulated via mathematical modeling. Dr. Gallagher, what assumptions must be made to simulate hyperemia during the CT-FFR calculations?
That's a terrific question because people often hear CT-FFR and understandably ask, how can you simulate invasive physiology without adenosine, without pressure wires, or without direct coronary instrumentation? And I would answer that it's through validated computational fluid dynamics and physiologic modeling. So we talked a bit before about how FFR CT is calculated in the podcast. Let's turn to those assumptions that are built into the model that you asked about. I think the first assumption is that resting coronary blood flow is proportional to myocardial mass. So the software estimates how much myocardium each vessel supplies and uses that to estimate baseline coronary flow demand. The next assumption is that microvascular resistance actually scales according to vessel size and myocardial territory, right? So larger vessels supply larger territories, and therefore they have different downstream resistance characteristics. And then third, and I think this is an important assumption, is that during hyperemia, the microcirculation responds in a predictable way. And CT-FFR mathematically simulates that reduction in resistance across the coronary tree. And I think the final assumption is that the calculations all assume that the hyperemic response is reasonably preserved. And I'll point out that in the real world, there are some caveats, right? So in patients with severe microvascular disease or diffuse fibrosis or left ventricular hypertrophy or prior infarction, this assumption can be complicated. But I do think we should maybe simplify that complicated answer. And I think there's an important perspective on this. And that's that every test in cardiology has assumptions, right? So stress nuclear imaging has assumptions, stress echo has assumptions, invasive FFR has significant assumptions, right? And I think the key question is not whether assumptions exist. The key question is whether the test performs well clinically. And CT-FFR now has been validated across multiple trials over the past nearly 15 years. Early trials, the Discover Flow trial was more than 15 years ago. The De facto trial, the NXT trial, and more recently, the Pacific trial, as well as large meta-analyses have all shown strong diagnostic accuracy compared with invasive FFR. So while the engineering and the assumptions are fascinating, I think what really matters to clinicians is that the outputs have really proven reliable enough to guide real-world care.
Thank you, Dr. Gallagher. That's really helpful insight into some of the assumptions and how to apply to our patients at the bedside. There is some very intriguing data regarding the accuracy of CT-FFR. As you mentioned in the Pacific trial, CT-FFR had a better accuracy than PET for predicting a significant stenosis on a per-vessel basis. However, there are also meta-analyses that show worsening accuracy when the CT-FFR values range from 0.7 to 0.8, with accuracy around 70% or even less. Dr. Gallagher, how do you interpret CT-FFR values in this intermediate range?
This is really one of the most practical and nuanced questions in all of CT-FFR. So thanks for asking. Because while we often talk about 0.80 as a cutoff, physiology is not binary. Coronary disease exists on a continuum. And CT-FFR values in the so-called gray zone that you mentioned require thoughtful interpretation. So if we think about values at the extremes, life is pretty easy, right? If the CT-FFR is clearly normal, say 0.88 or 0.90 or 0.93, ischemia is very unlikely. In fact, the data suggests that FFR-CT values greater than 0.9, there's a 98% accuracy in this setting. But if you look at the other end of the spectrum, if the CT-FFR is clearly abnormal, values like 0.68 or 0.71, that's much more convincing for physiologic significance. So here again, the data suggests with an FFR-CT value of 0.6 or less, again, high accuracy, 86% or above. But as you mentioned, between values of 0.75 and 0.80, or even FFR-CT values between 0.7 to 0.8, as you mentioned, depending on the context, we need to think more deeply. And this is where you really have to approach this with a bit more sophistication. So I'll walk you through how I approach it. First, I think the lesion location matters, right? So borderline value in a proximal LED that supplies 35% of the myocardium is very different than the same value in a distal branch vessel, like an obtuse marginal branch supplying 5% of the myocardium, right? So lesion location. The second thing I use as I approach is the translesional gradient. So if the vessel drops, if the FFR-CT values drop sharply across the focal lesion, for example, from 0.96 to perhaps 0.81 across a short proximal LAD lesion, that tells you something important. And this delta FFR-CT value of 0.12 or greater is considered significant, right? So translesional gradient. And then third, I think I always look at the plaque phenotype, and in particular in the segment of concern with a reduction in the FFR. What does the plaque look like in that area? Is it mild plaque? Is there heavy calcification? Is there positive remodeling? Are there high-risk plaque features? So the plaque phenotype in that area is important. And I think finally, concordance with anatomy. So when you're reading a study, does the CT anatomy support the physiology, or does that number seem discordant? So if you put that all together and realize that we don't practice in a binary world where 0.79 means take the patient to the cath lab and 0.81 means reassurance, we really practice in a clinical world, right? And frankly, we do this already with every other test in cardiology. We don't interpret stress tests purely by a number. We integrate exercise capacity and EKG changes and size of perfusion defects and whether or not the ventricle dilates and what happens to the blood pressure. So I think CT-FFR deserves the same level of sophistication. So in the gray zone, the answer is not just the number alone. The answer is the number plus anatomy, plus plaque, plus judgment.
Thank you, Dr. Gallagher, for that very nuanced and clear approach. To round out the CT-FFR discussion, a 2025 Lancet review states that clinicians should be careful about over-relying on CT-FFR. There are several situations where CT-FFR hasn't been validated for, including distal segments or stented segments. There is limited data for use of CT-FFR in the setting of severe AS. Additionally, a 2022 study in JACC cardiovascular imaging showed a decrease in CT-FFR accuracy for patients with increased coronary artery calcification. Dr. Gallagher, how do you approach CT-FFR use when there is excessive coronary calcification, and are there any other populations where CT-FFR use should be limited?
Well, thank you. Before we get into the specifics of accuracy with calcification in other difficult populations, I think it's important to make a few general points about the limitations. And I'd say the biggest practical limitation of cardiac CT probably isn't the algorithm. It's more related to image quality and the quality of the overall data set. But if we really turn to the specific question you asked about accuracy of CT-FFR with extensive coronary calcification and other difficult to image populations, such as severe aortic stenosis, these are really important real world questions because heavily calcified coronary arteries are common, right? especially in older patients or in patients with diabetes, chronic kidney disease, and that group of pre-TAVR population. And interestingly, the presence of significant calcification, in my experience, is actually one of the areas where I personally lean heavily on CT-FFR. And I say that because as clinicians and as imagers, we frequently overcall stenosis severity in calcified vessels. Calcium blooming can make a moderate lesion look severe, and then in turn, that often drives unnecessary catheterization. So I think in this situation, CT-FFR helps restore sort of a physiologic perspective. Now, it's not perfect. Specificity can decline somewhat in heavy calcification. But even in major studies like the NXT sub-analysis, CT-FFR maintained very good discriminatory performance across calcium burdens, even in the top quartile of calcification. And importantly, it reclassified many false positive CTA lesions into true negatives. So practically, if I see heavy calcification and a CT-FFR value is clearly negative, about 0.80, I find that very reassuring. If it's mildly positive in a heavy calcified segment or vessel, I interpret this with a bit more caution, and I often correlate clinically or with other testing. If it's clearly abnormal and anatomically it makes sense, it's concordant, then it becomes much more actionable. So my summary, I guess, would be heavy calcification is not a reason to avoid FFRCT. In many cases, it's actually a reason to use it, but just use it intelligently. And so briefly, I do want to make a comment about patients with severe aortic valve stenosis, as you asked. Again, severe aortic stenosis is an especially important subgroup because nearly half of patients being evaluated for TAVR, maybe more than half of patients, have concomitant coronary disease. So accurate, non-invasive assessment in this clinical context really matters, right, with your TAVR teams. So I do think CT-FFR is promising here, and early studies suggest it's feasible, but we need to remember that things like left ventricular hypertrophy and microvascular dysfunction and altered coronary hemodynamics seen in aortic stenosis can really shift the usual ischemic thresholds. So in practice, I guess I'd say I view a clearly negative CT-FFR with severe aortic valve stenosis as quite reassuring, but borderline or positive values should be interpreted more cautiously. And often you have to put that together in conjunction with the other clinical and procedural variables.
Now we arrive at what could be the most paradigm shifting development in cardiac CT, AI-based quantitative plaque analysis. Let's set the stage with a case. So we have Miss Athena Plaque. She's a 55-year-old woman with history of hypertension, hyperlipidemia, and family history of premature CAD. She presents with chest pain that is not clearly anginal. Her CT coronary shows non-obstructive stenosis. The maximum stenosis is about 40% in the mid-LAD. And by traditional criteria, she's a CAD-RADS 2. Her referring physician might be tempted to say, no significant disease, reassure her, and follow up in a year. Dr. Gallagher, this patient that has technically non-obstructive disease by stenosis criteria, but could be at high risk depending on plaque biology, can you walk us through what is AI-based plaque quantification and which of the metrics are ready for clinical decision-making today and which might be still, mainly just a research tool?
Well, thanks for the question. There's a lot in that question. So absolutely. In many ways, this may be the most important paradigm shift happening in coronary CTA today. As you mentioned, for years, we've primarily used CTA to answer a stenosis question. Is there a blockage? How severe is it? Does this patient need further ischemia testing or the cath lab? Of course, these questions are extremely important, but it's incomplete because the majority of future infarctions do not arise from known severe obstructive lesions. They often arise, as you know, from previously non-obstructive plaque that progresses or ruptures or erodes. So AI plaque quantification really changes the conversation from stenosis-centric thinking to more of a disease burden in plaque biology thinking. So let's turn to what plaque analysis is and how does it work. So AI-based quantitative coronary plaque analysis, or QCPA, we'll use that for short. What it does is it uses these deep learning algorithms applied to a standard CT data set. And this automatically identifies the coronary tree. It segments the lumen, the outer vessel wall, and it quantitates the plaque that lies between those boundaries. And it measures that plaque and it breaks it down into different parts: calcified plaque, non-calcified plaque, and low attenuation plaque. And importantly, it can also provide overall total plaque volume, or TPV, or percent atheroma volume, or PAV values. And these are really powerful. And they can compare patients with age and sex-based nomograms, right? And so this is important because plaque burden, especially non-calcified plaque and low attenuation plaque, can often predict risk beyond stenosis severity and beyond calcium score. And so when you ask about why is this changing the way we think about coronary disease, it's really, I think, shifting our focus from one of looking at ischemia to a lens atheroma. This matters because plaque burden and plaque phenotype often predict risk better, as we said before, and AI helps us quantitate that difference. So instead of us asking, is there a flow limiting stenosis? We now ask, what's the total burden of disease? What's the plaque biology? And how aggressively should we treat? And I think you did ask a bit about some of the research and research-based tools. I want to mention two quick studies that I think have really helped provide evidence to support the use of coronary plaque analysis. And I think the listeners should be aware of the REVEAL plaque study. That was really the first large study that correlated plaque analysis as determined by CT with intravascular ultrasound imaging, which is our invasive reference standard. And what these authors found is that the correlation coefficients were around 0.9 or 0.91 to assess total plaque volume and the plaque features, which is quite impressive. And there's been several other registries, including the CONFIRM registry and ADVANCE and post-hoc analyses of SCOT-HEART, all that have shown that higher plaque burden, especially non-calcified and low attenuation plaque, predict future events really independently of stenosis. So when you focus for a minute and you say, like, what's ready for prime time clinical use now in the world of plaque, I'd say the most relevant, useful metrics today are probably number one, total plaque burden. That's the most robust and intuitive measure. Number two, calcified versus non-calcified composition. That's really useful for understanding phenotype and treatment. Low attenuation plaque burden is also quite promising, especially in higher risk patients. And I think plaque staging systems are very important in percentile rankings. So the ability to stage your patient across a continuum of plaque values between P1 and P4 or stage 1 to stage 3 are really becoming clinically relevant, and they help in understanding how to treat our patients, and they also help in motivating our patients. So what's the bottom line? I think AI plaque analysis doesn't replace clinical judgment, but it really upgrades it and allows us to move from thinking about there's mild coronary disease in this patient to perhaps this patient has significant whole heart atherosclerotic plaque burden with high risk phenotype that requires aggressive prevention. So that's a really different conversation.
Thank you so much, Dr. Gallagher. That was so informative. And along those lines, if we look at also one of the exciting implications of quantitative plaque analysis is maybe using it to monitor treatment response. So there's a study, the Paradigm study, that showed that statins promoted conversions of unstable plaques to stabilized calcified plaques and reduced total plaque burden on CCTA. And then there's the Evaporate trial that shows that icosapent ethyl, 4 grams a day, reduced low attenuation plaque volume by 17% at 18 months, while the placebo group saw a 109% increase. That's a very striking results that actually provided mechanistic insights into the famous REDUCE-IT cardiovascular outcomes benefit trial. So Dr. Gallagher, are we moving towards a world where serial CCTA with AI plaque quantification can become a tool for monitoring atherosclerosis treatments, similar to how we use LDL levels or CAC scores?
Well, you've done your homework. You commented on some really important trials. And so thanks for the question. I think the honest answer to your question is we're moving in that direction, but we're not there yet, or at least not routinely yet. However, there is strong biologic plausibility for this concept. If atherosclerosis is a dynamic disease, and if modern therapies can actually stabilize plaque or regress plaque or alter plaque composition and reduce inflammation, then ideally we'd like to visualize that process directly rather than infer it only through, as you mentioned, LDL numbers. And I think CTA really is uniquely positioned to do that because it can distinguish calcified plaque from non-calcified plaque. And that's critical because calcium scores alone can be misleading in the patients that we treat. I think most are aware that statins often increase plaque calcification, while at the same time they stabilize plaque biology, right? So a rising calcium score does not necessarily mean worsening patient risk. So I think CT gives us a more nuanced view. And we do have data to support this. You mentioned two of them. I'll briefly comment. So the Paradigm trial, as you mentioned, was landmark. It showed that statin therapy was associated with slower progression of plaque, with a reduction of non-calcified plaque growth and increased calcification. So overall, these things were consistent with stabilization of plaque. And you also mentioned, I think, really the fascinating Evaporate trial by Matthew Budoff and colleagues. In this trial, patients with elevated triglycerides on statins, icosapent and ethyl reduced low attenuation plaque volume while placebo patients had progression, as you mentioned. So those are important trials. And I think the question then comes back to why not do serial CTA routinely now? And I guess I'd frame my answer with perhaps a few reasons. First, we have no randomized outcome trials yet. We do not have definitive evidence that repeating CTA and changing therapy based upon plaque measurements actually improves heart outcomes. And I think second, standardization is important, right? So if you have serial comparisons of patients who undergo a CT, there's some limitations regarding scan quality and protocols and hardware and reconstructions and software. And we need to make sure that we scan the patients on similar machines with similar protocols and similar reconstructions and similar software. So we have to get through that standardization hurdle. And then third, I think importantly, timing. Plaque biology really changes slowly. And scanning too early might perhaps create noise more than signal. So how I see it today, perhaps, is I think that serial imaging for plaque assessment is probably most reasonable in a select group of higher risk patients where repeat CTA is already indicated clinically, right? Or where there's like major uncertainty about disease trajectory. But in the future, to your question, I do think we're moving towards a world where plaque burden may become a treatment biomarker, very much like in the oncology world, where we follow tumor burden. But we still need more evidence before that becomes a mainstream guideline-driven practice.
Oh, Dr. Gallagher, thank you so much. That was super, super comprehensive and helpful. So before we close, maybe can you just summarize your main takeaway for CardioNerds about all of what we touched on today? Maybe a little summary.
So thanks for the question. Yeah, I think I would summarize everything we discussed perhaps in three pillars. The first is that CTA gives us anatomy. CT really remains one of the most transformative tests in cardiology, right? Because it detects both obstructive and non-obstructive disease, often earlier than traditional pathways. I think the second pillar is that CT-FFR gives us physiology. And with that, it improves specificity. It reduces unnecessary invasive angiography, and it really helps match anatomy to actual ischemic significance. And I think the third pillar is related to plaque. And AI plaque analysis gives us biology, and it helps quantify the total burden of atherosclerosis. It helps us identify higher risk phenotypes and personalize preventive therapy. And so if you bring all these pillars together, I think the question changes from, is there a blockage, to how much disease is there? Is it flow limiting? Is the plaque dangerous? Is there inflammation? And how aggressive should our treatment be? And that's fundamentally a better question. I really think that's where cardiovascular medicine is heading. It's from a late stage reaction to earlier detection of disease, to precise prevention and personalized care. I really think that cardiac CT is becoming one of the most powerful tools that we have, not only to diagnose coronary disease, but to prevent the next event. And I think part of our job and task and the art is learning how to use this information wisely, not overreacting to every plaque, but also not falsely reassuring patients with high risk non-obstructive disease.
Dr. Gallagher, thanks for this fantastic discussion. I'm so excited to see what the future of CT coronary looks like, and how can we be more proactive and not reactive. To finalize our discussion today, we wanted to ask you, in a typical CardioNerds fashion, what makes your heart flutter about cardiac CT imaging?
My heart flutters. So honestly, I think it's that cardiac CT lets us really see the invisible before it becomes a major problem, right? So for decades in cardiology, we've often just waited for symptoms or looked only for severe blockages. And I think what makes me excited is that cardiac CTs change that. In a matter of literally a few seconds, we can non-invasively visualize coronary arteries, identify hidden plaque, understand whether a blockage truly limits blood flow, and increasingly predict future risk. And that's really powerful. I think what excites me the most is that cardiac CT combines anatomy and physiology and plaque. And this is all really aimed at helping patients avoid heart attacks. And as a cardiologist, there's something really rewarding about showing a patient their own arteries on the screen and helping them understand their own risk, and then watching their behavior change over time. And this changes the course of their future. So I think what probably makes my heart flutter is that cardiac CT isn't just imaging. It's really a roadmap to an earlier diagnosis, to smarter decisions, and overall to better outcomes.
Well, thank you so much, Dr. Gallagher. That was a fantastic episode and very, very amazing insights into cardiac CTA. Thank you, Chris. Thank you, Mariana, for co-hosting this episode. And most importantly, thank you so much to all of our listeners at CardioNerds. We were very happy to provide this episode to you all. And until next time.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Julia Marquez. I am an intern in the CardioNerds Academy House Thomas, and I'm a 6th-year medical student at Albert Einstein University in São Paulo, Brazil. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.